Hello everyone. Let's start part 2. Okay. Clinical enzymology. What is the point of this lecture? I will cover, of course, all different objectives, inshallah, but this lecture as well is very easy to understand. There's a bit more memorizing more than there is understanding, but nonetheless, it's still important. And once you get the main idea on what to look for in the question, you will know how to answer immediately. So let's begin. What are the enzymes? They're biological catalysts, of course. They are very efficient. They're proteins, substrates, part of tissues, and assay by measurement of rate of specific reactions catalyzed by that enzyme. This is basically measurement of serum enzymes. This is the point of diagnostic enzymology, because enzymes normally are intercellular. In other words, they're only in most enzymes, you only find them within a cell. And in the blood, they're low concentration. So if there is release by leakage into the blood, it indicates something is not going right. Cell damage, either by cell death, hypoxia, brute force, trauma, or intracellular toxicity. So we can get quantitative values of the extent of tissue damage by seeing the level of the enzyme. And this procedure is non-invasive because take a blood sample is very simple, only it takes the needle. Unlike other tests where you see the state of organ, for example, like biopsies, and these are more invasive. Now, organ specificity. Now, what it talks about here is that many enzymes they can pinpoint you to where is the issue. So it can help you come to a more specific kind of diagnostic conclusion. Where is the problem at hand? Is it the prostate? Is it the bone? Is it the liver? Because each of these, they will have a specific, like some share, but certain body parts or organs would have specific. Hence the case of not absolute, but some can directly pinpoint us and shape us our track of thought to a certain direction. And most enzymes are present in most cells, differing amounts. Tamam? No. Obviously, by saying enzyme serum in the measurement, this measurement of it, we'll see if there's a presence of a certain disease, which organs are involved, and the nature of the disease. So it helps us for a differential. And the extent of disease for either, so obviously when there's more damage, so let's assume a cell, a certain enzyme that can be identified if released during trauma. So if there's more amount of enzymes in the blood, it means you were more punched, more traumatized. So there is more leakage of cells. And obviously the time course of disease, this is especially important when we talk about cardiac enzymes, because that will tell us when the MI occurring, and I'll go into more details about that later on. The one you're going to explain what are isoenzymes. We said that they're enzymes that produce the same reaction, but are structurally different, and they have different kinetics. And different isoenzymes may arise from different tissues, and their specific detection may give clues to the cytopathology. On various enzymes of an enzyme can differ in three major ways, either as enzymatic properties, physical properties, enzymatic such as its kinetics, and physical properties such as heat stability, pH, biochemical properties as amino acid composition, and immunological reactivities. Pretty straightforward. Now, you already discussed, for example, the laboratory techniques of enzymes. Now, which are the first few, the enzyme assays, etc., microarrays. Now, diagnostic and therapeutic. This what we'll be focusing on primarily in the entire lecture, especially diagnostic. Now, we have something called functional and non-functional enzymes. What does that mean? Functional enzymes are ones that you'll find in the blood to do a specific role for things relating to blood. It is blood clotting factors or plasma, where these are important. So they're functional in the blood, in plasma. While non-functional are things you shouldn't be there, just CPK, LDH, ALT, and so on. One function in plasma, specific function, functional, but non-functional, non-specific, it shouldn't be there. See, it's small amount only. And only when there's a clinically important issue, like a disease, would you notice an increase in the non-functional enzymes. So increased here, and functional will be decreased, such as, for example, people who you cover the different causes in HLS, but people who are more exposed to bruises easily are kind of over here. Blood factors, it's your plasma. And here, of course, tissue destruction or necrosis from which the enzyme originates. Now here's the diagram, obviously, basically re-explaining the entire idea of what happens or what causes a non-functional enzyme to enter the blood. Simply that when there is a certain kind of trauma, like see, in normal cases, there's no wear and tear tissues, right? So you'll always find very minute amounts of this enzyme in the blood. So there's always some wear and tear. So you'll find it here. So, but it's low. But what happens is when there's, for example, cancer, right? When there's cancer, the large amount of cells above the normal limit. So now they're continuously dying and reproducing. So you will notice that this plasma enzyme level is increased. Or, for example, let's again blunt force trauma, large amount of tissue has been damaged, directly goes in. Or necrosis during a heart attack, على طول, more enzyme enters the blood. And these are examples, and we go through them. Same point. Okay. Now, what would cause an issue for the enzyme? Obviously, higher than normal, either increased cell damage, like trauma, or cell proliferation, such as cancer, where since there's more cells, there'll be if there's more growing cells, there'll be more dying cells, hence proliferation. Now, what causes enzymes to be less than normal, either from the synthesis and inherited deficiency? So the enzymes in disease, two basic conditions, where the abnormal level of enzyme is the fundamental cause. Basically, a disease arises from decreased enzyme, so it's typically a genetic error. So this genetic error, there's a problem with the transcription and translation. So there will be the faulty or absent enzyme, in turn, leading to either the accumulation or the absence of a certain metabolite that the body needs or should be able to remove. Therefore, most are therefore the one would show you certain disease. Most are observed after birth due to maternal metabolites or metabolism. What does this mean? Is basically why during, for example, tests prenatal prenatal tests, basically as the woman is still pregnant and you take samples of the amniotic fluid or whatever. Why don't you detect this? Because the maternal blood, due to the exchange with the placenta, is providing whatever is needed, whether to remove the enzyme, certain metabolites, or to provide certain metabolites. So the placenta is providing what the fetus needed to develop accordingly. But on its own, it's insufficient, which is why you will detect it after birth. Now, therapeutic strategies for enzyme deficiency diseases include dietary modification and potential gene therapy or direct enzyme replacement. Basically, sometimes you could have a deficiency in the enzyme just by not eating properly, so by fixing it with diet. Or now, this is more new, more recent class of treatment where there's gene therapy, which help manipulate modify the gene to help improve with the natural body transcription and translation, or direct enzyme replacement where you just give the enzyme directly, such as people who are lactose intolerant, where now there's something called lactaid, which helps in that. Now, where the abnormal enzyme activity is the consequence of disease, this is the second way where enzymes and diseases could correlate together, is that you will notice an abnormal enzyme level or activity due to a disease. Unlike in the first where we said a disease arises due to the lack of the enzyme, it's now like the other way around, where the absence of the disease, so the absence of the enzyme or the under activity causes the disease. Now, checkpoint. We study enzymes to be able to reach different differential diagnosis and how it occurs, either by bad genes or due to a bigger problem like a disease that is causing the enzyme to be weak, such as cancer. And in 99% of cases, elevated enzyme is bad. It's only like one case here that elevated enzyme is the normal, like it should be high, and only when it decreases, that's a problem. Besides, of course, the blood clotting factors. طبعا here, your doctor already said you don't need to know this, but this is just a way, This is just a list of diseases that occur due to a fundamental absence of a certain enzyme. So it's due to this fundamental cause. And due to the absence of this enzyme, you reach these different problems here, different symptoms and abnormalities. Okay, now principal diagnostic enzymes. Now here is where it's gonna get a bit annoying. See all of these, there is not much to understand on how it works, more there is just need to memorize. But there's a few points I would like to cover in each one. Obviously, you don't need to know the number. They will either tell you it's elevated or give you the normal level and tell you the level in the patient. Don't need to worry about memorizing the normal path levels. So طبعا you have ALT or SGPT. These two mean the same thing. Major diagnostic use for liver disease. Now you have AST or SGOT, Scott. تمام. You will notice an increase when there is either an myocardial infarction and a liver disease. Then CPK or CK for MI, muscle disorder, or crush injuries. And lactate dehydrogenase, either MI or muscular dystrophy. I'm going to go through these quickly because these enzymes will again be mentioned with more specific disease list of diseases shortly. ALP is either obstructive jaundice or liver disease. Acid phosphatase, prostate cancer. So basically, and this is the case, for example, if you see any blood test, and directly you notice an acid phosphatase level above the normal, you can directly, as we said, the point of testing the enzyme level, or when you want to take a blood sample, see what is called the issue, you can directly reach a differential and help you become more confident in your differential diagnosis that it is, for example, prostate cancer by directly seeing what there's only acid phosphatase level increased. Now we have ALP, we said this acid phosphatase. Now amylase and lipase both are released by the what do you call it? The pancreas. So that's why they both can be seen to have acute pancreatitis, and an amylase though, it can show mumps. And then you have GGT, that can be shown for liver disease or chronic alcoholism, which is basically, when people sometimes will want to check if they are alcoholics, like for example, for a work wants to see if you have an alcohol problem, they would actually request a blood test and see your GGT levels. Because we know that alcoholism would cause liver damage, and this is one of the enzymes we observed. And this is the only case where it's a problem when the enzyme level is decreased, Wilson's disease, due to a decrease in ceruloplasmin or serum peroxidase. So we use all of these to be able to profile the disease, right, and see certain patterns. So for accurate diagnosis of particular disease, more than one serum enzyme are routinely estimated instead of a single enzyme. Because basically, as you noticed here, ALT and AST show liver disease. So what if you have AST elevated? And it could also mean myocardial infarction. But what if, and see, many diseases can intertwine together. You see AST, CPK, LDH, all show MI. So which one is it? But at the same time, AST also shows liver disease. So due to the intermingling and different levels, we need to do multiple and check for different specifics to be able to be sure. So this and this. Okay. Now I'm shamelessly because my team, Anki, it is good to help memorize this lecture. Specifically, I used it. Great, much wow, very cool. Try Anki. Now, we will go now more specific to the different diseases. So obviously we have myocardial infarction, where three main enzymes you notice an increase in is either CPK2, also known as CKMB, AST, or LDH1, H4. I will cover this in a bit. Now, liver disease, you will either see ALT, AST, or ALP increased, and gamma GT or LDH5. See, there's no difference. They're both LDH, but these are what? The different types of isoenzymes. And also, as I say here, ALP can be seen in obstructive jaundice, infected hepatitis, alcoholic hepatitis, hepatocellular carcinoma. GGT is used for the diagnosis of alcoholic liver disease and increase in liver disease, especially in obstructive jaundice. So you can see again how ALP and gamma GT can be seen with obstructive jaundice. So again, the idea of the intertwingling of both factors of different enzymes. So you need to keep testing and comparing to reach final definite diagnosis. Most of disorders, you'll have CK3 or LDH5, such same as liver disease and or AST. Then you have alkaline phosphate, which is Paget's disease, or osteomalacia, rickets, or osteoblastoma. I know I am just reading and it's a bit boring, but this is how the questions will come. You need to just memorize which disease is caused and by which elevated enzyme levels. But I'll cover a concept of now. Now we have obviously in pancreatic diseases, you have alpha amylase and marked increase cause can be acute by acute pancreatitis or severe glomerular impairment. Moderate increase, which can cause perforated septic ulcer, acute cholecystitis, intestinal obstruction, thyroid gland disorders like mumps and salivary calculi. Lots of reading, right? But there's something I want you guys to notice. You see how, for example, ALT is only for liver disease, and AST can show liver disease and myocardial infarction. So this shows that ALT is more specific to liver diseases. So if let's assume you were limited to only one test to see whether the situation is, you should go for the more specific to see what's the issue. Is it liver disease or AST? Tamam? Same applies to other conditions. For example, phosphatase is prostate cancer, right? So this is very specific. So if you're doubting prostate cancer and you want to test, directly just look for the phosphatase level. There's no need to go for anything else. And if you look at terms of specificity for now acute pancreatitis, what is more specific? Would you look at amylase or lipase? It's lipase because amylase can also show problems with mumps. While lipase, when there's an increased level, it's only acute pancreatitis. So just have this constant mind where if there's an overlapping of certain enzymes, look for the disease that doesn't. For example, in myocardial, where is it? For example, if you want to look at anything related to the liver and at a complete definite conclusion, look at the GGT levels. Because if you have ALT, you could say, sorry, if you have elevated where is that? Make sure. You have elevated AST levels, but you're not sure whether he's having an MI or liver disease, you would look at his GGT. So then you would say, oh, he doesn't have a problem with his heart, it's a problem with his liver. So it's the GGT and it's ALT, sorry, ALP. Obviously, as you said earlier, for example, pancreas, there's alpha amylase and there's lipase. And lipase is more specific because alpha amylase can cover other things like acute pancreatitis, so on, and mumps. See, as is here. Now, let's look at the isoenzymes. Again, you need to just monkey style it and just memorize where the different isoenzymes have different compositions. So CK1 is BB, CK2 is MB, CK3 is MM. What does M and B stand for? It's either an M subunit, that is basically skeletal muscle subunit, or a brain subunit. So if it is entirely in the brain, if it's BB, so 2B, so only a brain, so it's only a problem in the CNS diseases. But if you have MB, you can have a problem in the muscles of the heart. So it can be a CK2. So remember it, two as in two different types of subunits, M and B. But CK3 and CK1 are on its own. So we have MB, elevated in acute MI, and CK3. MM, skeletal muscle only, since we have two skeletal muscle units, so it can be skeletal muscle, or again, a problem with the myocardium of the heart. We know the heart has different endocardium, so yeah. LDH, lactate enzymes catalyze the reversible conversion of lactate to pyruvate. Increased total LDH is relatively non-specific. LDH isoenzymes can be useful. In what case, you'll see shortly. But as we said, there's 5 different types: LDH1, LDH2, 3, 4, 5. Each one going from 1 to 5, the H decreases and the M increases. So you know LDH1 has no M, only H. LDH2, you give it 1 M. LDH3 now 2 M. 4 has 3 M. And 5 has 4 M. So again, memorize it and see it fit. Like the way I would try to I remember it was that like always count from m. So let's assume you do 5 minus 1, that's 4m, and 1 minus 1 is 0m. So LDH1 is 0m, so it's all 4 HHs. LDH2, so 2 minus 1 is 1, so 1m, you have 3H and 1m. And then you'll see that LDH1 is shown in cardiac RBCs, LDH3 lung, spleen, pancreas, LDH4 hepatic and skeletal, like mentioned earlier, LDH5 as well for other things. LDH post MI, and this is now this is where we're getting important for the cardiac to know when he gets MI and how severe. If we look at post MI, acute myocardial infarction, there will be an increase from 10 to 24 hours, and it will peak 40 to 72. Basically, from the start of the MI, it will increase, right? But you will notice levels from reach its maximum point either at 48 between to 72 hours, right? Afterwards, it'll start decreasing, but you will notice levels elevated above the normal for up to 10 days. And the issue with LDH1 is that although it is specific to MI and it's sensitive, there are better choices to look nowadays. Especially because it doesn't always necessarily respond immediately after 12 hours. So, because we know that sometimes an MI might be undergoing and no symptoms are showing. So we don't know, we cannot exactly pinpoint when is it happening or when it happened. And so it can detect minor infarcts, exactly, because we cannot tell when is it happening and how severe has it been going. Like he could come 3 days after the MI. So within 3 days, you notice an elevated level for the LDH, but it wouldn't have shown exactly relative to his symptoms. This entire slide, the emphasis is that usually LDH2 should be the highest out of the 5. This is the normal conditions. But excuse me. This is a problem only when do we know there's an issue with the per patient? If you notice the LDH1 in comparison to the total is the highest, or as here, ratio is less than 40. In other words, LDH1 is greater than LDH2. And when we see an LDH1, we know that it is consistent with the problem with the heart. This is an AMI. طبعا again, ALT and ASP, AST. It's explaining what do they do in the liver, elevated in the blood, leakage from damaged cells. Measurement of these transaminases is useful for the diagnosis of liver disease. In viral hepatitis, the enzyme levels are increased 50 times above the upper limit. But if you see here, as we mentioned earlier, specificity, since which one is more specific to the disease. When you look at ALT, it is more indicative of liver damage involving hepatocellular damage, right? But AST, it is less specific because it can be increased to either to muscular dystrophy or an AMI. So if you want to be sure, is there an issue either between the muscles or etc., focus more on the ALT because it'll be more specific to liver issues. طبعا these points here discuss what makes the best cardiac marker. It's very sensitive, highly specific, and it has analytical characteristics such as simple perform, rapid turnaround time, and efficient precision. I personally haven't seen any question relating to this, but this is just a good thing to understand that these factors is what would make the cardiac marker to know when and the severity of the MI as soon as possible. Like for example, rapid release and long half-life. Clinical characteristics, ability to influence therapy, and ability to improve patient outcome. Does everyone understand everything so far? I know I've been talking a lot. Tamam. Now, this is where we need to focus because this is where the bulk of the questions will show. This is my experience anyways. We need to look at the cardiac enzymes. In the good old days, AMI is diagnosed with the cardiac enzymes such as CPK, LDH, and AST, which we covered earlier, right? But now, we have more specific markers with better half-lives and that we can use. So CPK, LDH, and AST, these of course are all you still need to know them and not now disregard them saying they're no longer used for the heart or they show the heart's undergoing AMI or not. But they are now better when things to look at is troponin I, myoglobin, and CKMB. And this is the famous graph regarding it. The triage, or called, you look at CKMB, troponin I, and myoglobin, and notice how different enzymes have different peaks and different lifespan. And this is very important to know what happened to the patient, when is he walking in, and how did it occur, or not how, more as when. The times are here. Again, very important to memorize all of this because very easily they will tell you a patient came, a patient was suffering from cardiac arrest, sorry, AMI-like symptoms for a week, and then it comes to the clinic. So directly, you need to start understanding, okay, a week. So obviously more than 7 days have passed by. So you need to start comparing times to know what is going on. So obviously, if you look at this little table here, myoglobin is the most sensitive and will respond first to a change and to directly increase in 2 hours. The problem with myoglobin is it peaks at 6 to 8 hours, and within less than 2 days, it returns back to normal. And there are many cases where patients come to the clinic several days after they're started undergoing an MI. So if you only look at myoglobin and its normal levels, and although he's suffering from it and his case will get worse, the myoglobin levels look like he's fine, there's nothing to worry about. Now, troponin I, always look at this when there's anything related to a guy traveling or a long period of time before he has entered the clinic. Because although it takes a few more hours to start increasing and reach its peak, it stays in the blood the longest. The second thing is then you have CKMB, shows a similar pattern of increase and peaks to troponin I, but the thing is that CKMB just can't peak might need an entire day to reach its peak, and it will take 72 hours or 24, 48, 72, takes around 3 days to go back to normal. The longest that will take before you can approach his normal level and you can think that he is normal is the troponin I. So when in doubt, observe the troponin I. But if a patient says he suddenly felt pain, directly look at his myoglobin and ideally myoglobin. He says he likely felt pain, check myoglobin. It should have been directly the first thing to increase. When the interpretation of cardiac markers can be difficult because blood specimens are not always collected soon after the patient suffers chest pain. Delays of hours to days are common for patients seek medical attention. I already covered this. Now, we've discussed basically now the cardiac markers. Did you ever understand this? All right. Yes, okay, great. Now, the second part is now a therapeutic use of an enzyme. Now, whenever we have an MI, we want to treat it as soon as possible because the longer we wait, the more likely, or not more likely, the more the patient will be at risk, something you learn down the line of something called reperfusion injury. And we don't want that. We want to treat as soon as possible to reduce this issue. So we use enzymes, of course, to treat it. We use either streptokinase, urokinase, or TPA. And these are proteases, as in the proteins that break down the clot that's formed, because we know the clot contains fibrin, it's a protein. To break down the fibrin clot, we use its opposition, which are proteases. So it is used in treatment to dissolve intravascular clots in MI or deep vein thrombosis. And this is basically how the mechanism of the pollen proteases work, that by giving streptokinase or TPA or urokinase, any of these three, please memorize them, it will activate plasminogen and start forming plasmin. And plasmin is or consonant cannot form, more like convert from plasminogen, which is a zymogen. You know, zymogen are the inactive form of an enzyme. It will convert it to plasmin and can break it down to fibrin. Break down the fibrin to now reopen the artery or remove the vein. You know, the vein thrombosis. Other enzymes for the diseases are asparaginase for use for leukemia, trypsin and lipase for pancreatic insufficiency. Again, just memorize, not much to do. But I mean, you can understand that trypsin and lipase, for example, without memorizing a pancreatic insufficiency, you know that, just one sec, you know that these enzymes are what produced from the pancreas to help in the GI tract process for digestion. So obviously, if there's an insufficiency, and your body needs to digest these products, so you will give as a treatment for the pancreas not able to produce them, you would give directly these enzymes. And lastly, obviously, I'm going to just go over these really quickly. Just that, because you already covered these, that enzymes are for laboratory reagents, such as check estimation of concentrations of substances, DNA analysis, or ELISA technique. And we know that in the estimation, you can use a chromogen reagents by checking the colorimetry, or for analysis by PCR, so you need DNA ligase, polymerase, and resection nucleases. And of course, why do you need DNA analysis? To check for diagnosed genetic diseases or infectious diseases. ELISA for tools, check for wide antibodies, hormones, and viruses. Now, in summary, how do enzymes end up in the bloodstream? Due to trauma or proliferation. So that causes more cells are reproducing or regenerating, so there's more cell death, or due to an issue that's affecting the organ or the tissue itself. Directly it will start leaking into the blood. And enzymes are related to diseases either acquired or fundamental. We said acquired as in it is a secondary result from the disease, such as cancer. As you said, it's correlating to a second ago, where cancer, there's a large amount of new cells, so a large amount of new dead cells. So you acquire a large amount of enzymes in the blood. Or fundamental, where due to bad genes, you will get a problem and result into a certain disease. Specificity, I'll now go back to the table. As you noticed here, for example, ALT and AST both talk about liver disease, but what is more specific to only liver disease? ALT. Same thing goes to lipase and amylase. What is more specific? It's lipase, because it only covers acute pancreatitis, but amylase can cover both. And same with ALP, we said there's liver disease as well, but it also covers obstructive jaundice and bone disorders. And of course, please don't forget that it's good to memorize all of these. It's easier than you think, just with a bit of practice and it'll go good, inshallah. Now, what else? So in summary, obviously, LDH1, we said if it's greater than the total LDH levels, it is an indicator of MI, but it is not always, only 90% in cases, then it will respond quickly and it can be reliable. There are better choices, which are what? The triage. And this is also very important. You need to know what are the triage. Because here, and don't get confused between the old and the new. The old one is CPK, LDH, AST, but the current trusted triage, even to this day, if you go to hospital, see a blood test, and if there's any concern, they'll check for troponin, CKMB, and myoglobin directly. These three are what are the triage, not the old ones. Focus on the new three, so that can be from scratch. But they can easily tell you what are the triage enzymes used for as a cardiac marker. If you see LDH, CPK, wrong. It is troponin I, CKMB, and myoglobin. Now, therapeutic uses, which is for leukemia, asparaginase, or using for DVT or MI, you use TPA, urokinase, or streptokinase, right? Yeah, streptokinase. And lastly, the different lab uses, which you've covered in already 2 other lectures beforehand. Now, let's practice. High levels of alpha amylase indicate what? Who was focusing?
C.
صح, exactly. C. طيب, next. The first cardiac marker to increase is what?
Myoglobin.
Wahsh. Great. Everyone understand the first two questions? On an eye and oops. Understand why it's myoglobin? Because if you look at the table here, where is it? Look at the graph. The first thing to respond and speak is myoglobin. The rest will shortly follow. So in a short period of time, if someone comes, it's myoglobin that will increase first. Okay. Now, which of the following is the best cardio marker if a patient after 4 days of chest pain is admitted to the ER? This was a previous batch question. So let's cancel out what is not related to MI or chest pain. It's not amylase, obviously. Amylase is for either mumps or pancreatic problems, acute pancreatitis. You have these three, right? No, you don't. What else should be removed? ALT, صح. ALT is only specific to what? Liver. Remember,
Liver.
exactly, specific for liver. So we don't want this. LDH5. Was LDH5 the thing we observe when we want to see if it's an MI? No, it's not. It's LDH1. Lopus for muscles, exactly for LDH1. And what we want to look for when it comes to the heart. So we remove B. We are left with CK and troponin I. This is where you need to know when does the levels reach to normal and when does it peak. Tamam? CK takes 3 days. So that's 72 hours to reach normal levels. So that means, and he comes to you after 4 days. So we know that myoglobin, myo, and PK, khalas, they've long reached normal levels. So it will no longer show you anything. But what would have stayed in the blood the longest? The last answer, of course, by probably troponin I. Troponin I lasts for 6 to 10 days. Look back here. Look at the table here. This table is to be your best friend any question coming relating to AMI. Know all of these. Because if you just simply memorized what occurs and compare the time the patient comes in, so in case he came after 4 days, in other words, 4 days, which is now, just 1 sec, just want to think, 4 times 24, 96 hours. And nothing can reach this amount of time except troponin I. Does that make sense, everyone?
Yes, thank you.
I think with that, thank you, everyone. Have a lovely day. Good luck on your studies. If you have any questions, these are my contacts to reach me. If you have any questions regarding lectures or any other lectures you have a problem with. And I'm glad, I hope I was able to help you guys, and best of luck. Yeah.
Thank you, Kenan.
My pleasure.